Right now, in your body, a silent biological catastrophe may already be underway. Not might be, may already be. And the most disturbing part is not the catastrophe itself. It is the fact that the warning signs have been present, visible, measurable, and clinically significant for years before the diagnosis is made. Years during which the damage to your kidneys, your nerves, your eyes, your cardiovascular system, and your brain has been accumulating quietly, steadily, and largely irreversibly. The average American over 60, who is eventually diagnosed with type 2 diabetes, has been living with significant insulin resistance and metabolic dysfunction for 7 to 10 years before that diagnosis is made. 7 to 10 years. A decade of progressive vascular damage, a decade of nerve fiber deterioration, a decade of kidney filtration decline, a decade of accelerating cardiovascular risk, all occurring silently, without a formal diagnosis, without targeted intervention, and without the individual having any meaningful understanding that their body has been sending them specific, identifiable warning signals the entire time. Signals they dismissed, signals their physician may have minimized, signals they were never taught to recognize as the early language of metabolic disease. This video is about those signals, the ones nobody talks about, the ones that do not appear on the standard checklist that gets recited in the 10-minute annual physical, the ones that are subtle enough to be dismissed, normalized, or attributed to aging, but that, properly understood, represent the earliest and most actionable window for intervention that exists in the entire progression of type 2 diabetes. You deserve to know what they are, and you deserve to know what to do when you recognize them. Here is a number that should stop you completely. 37 million Americans currently have type 2 diabetes, and 96 million Americans, nearly 1 in 3 adults, have prediabetes, the metabolic state immediately preceding type 2 diabetes, characterized by blood glucose levels above normal but below the diagnostic threshold for diabetes. Of those 96 million Americans with prediabetes, 80% do not know they have it. 80%. And of those who are diagnosed with prediabetes, only approximately 5 to 10% receive the structured, targeted, evidence-based intervention that has been demonstrated in the landmark Diabetes Prevention Program trial to reduce progression to type 2 diabetes by 58%. These are not statistics about a rare condition or a marginalized population. These are statistics about an epidemic that is affecting the majority of the American population, over 60, quietly, progressively, and without the urgency it deserves in either clinical practice or public health messaging. After the age of 60, the prevalence of type 2 diabetes reaches approximately 30% of the population, and the prevalence of prediabetes in this age group is estimated at an additional 30 to 40%, meaning that somewhere between 50 and 70% of Americans over 60 have either established type 2 diabetes or the metabolic dysfunction immediately preceding it. The majority of those individuals are not receiving optimal management. The majority are not engaging in the specific targeted interventions most strongly supported by the evidence for slowing progression and reducing complication risk. And a substantial proportion do not yet know that they are metabolically at risk. Why does this matter so profoundly for the specific population of adults over 60? Because the complications of type 2 diabetes, cardiovascular disease, chronic kidney disease, peripheral neuropathy, diabetic retinopathy, cognitive decline, accumulate as a function of the duration and degree of metabolic dysfunction. Every year of prediabetes progressing toward type 2 diabetes unaddressed represents another year of endothelial damage, another year of advanced glycation end product accumulation in arterial walls, another year of inflammatory burden on the kidneys, and another year of progressive nerve fiber degeneration in the peripheral nervous system. The window between the first appearance of warning signs and the establishment of irreversible end organ damage is not unlimited. It is measurable, finite, and closing with each year that passes without recognition and intervention. This is not meant to produce fear. It is meant to produce urgency, because urgency is the only appropriate response to information of this clinical significance. You already know the textbook symptoms of diabetes: excessive thirst, frequent urination, unexplained weight loss, blurred vision. These are the symptoms that appear in every pamphlet, every health website, every public health campaign about diabetes awareness. And here is the brutal truth about those textbook symptoms. By the time they appear with sufficient severity to be recognized as alarming, the metabolic dysfunction driving them has typically been present for years. The textbook symptoms of diabetes are late-stage warning signs, the clinical expression of a metabolic derangement that has already crossed the diagnostic threshold for established type 2 diabetes, and in many cases has already produced measurable early complications. They are not the early warning signs. They are the announcement that the early warning window has already closed. The warning signs that matter, the ones that appear years before the textbook symptoms, during the long pre-diabetic transition, when intervention is most effective and end organ damage is most preventable, are different. They are subtler. They are more easily normalized and dismissed. And they are the ones that nobody talks about with the directness and specificity they deserve. Let us also address something that the standard diabetes narrative gets consistently wrong about the population over 60 specifically. The classic presentation of type 2 diabetes, the pronounced polydipsia, polyuria, and unexplained weight loss that drive most younger adults to seek evaluation, is frequently absent or significantly attenuated in older adults. The thirst mechanism, the physiological response to rising blood osmolality that drives fluid intake in younger individuals with hyperglycemia, becomes progressively less sensitive with age. Older adults with significantly elevated blood glucose levels may experience only mild or intermittent thirst, or no pronounced thirst at all, removing one of the most reliable subjective warning signals from their clinical picture. The renal glucose threshold, the blood glucose concentration above which the kidneys begin to spill glucose into the urine, driving the increased urinary frequency characteristic of classic diabetic presentation, rises with age, meaning that older adults may have significantly elevated blood glucose without the pronounced glycosuria and secondary polyuria that would prompt evaluation in younger patients. What this means practically is that the classic textbook symptoms are even less reliable as early warning indicators in adults over 60 than they are in younger populations, making the recognition of the subtler, earlier warning signs we are about to discuss even more critical for this specific demographic. Warning sign 1. The fatigue that coffee does not fix. Not the normal tiredness of a physically demanding day, not the sleepiness of a poor night's sleep. A specific pervasive cellular-level exhaustion that is present from the moment you wake up, that persists regardless of how much sleep you obtain, and that is not meaningfully addressed by caffeine. This is not tiredness. This is cellular energy failure. When insulin resistance prevents glucose from entering muscle and other peripheral cells efficiently, those cells are literally starved of their primary fuel substrate, despite having adequate or even excessive glucose circulating in the bloodstream just outside their walls. The cellular machinery of energy production, the mitochondria, are operating on a depleted fuel supply, generating less ATP, producing less cellular energy, and generating the subjective experience of profound, persistent, treatment-resistant fatigue that is one of the earliest and most consistent but least specifically recognized symptoms of insulin resistance. You have been calling this aging. You have been calling it being out of shape. You have been supplementing with B vitamins and iron and CoQ10, trying to address a symptom whose actual cause is metabolic dysfunction that none of those supplements touches. The fatigue that does not respond to normal rest, that is present consistently and pervasively across multiple weeks or months, that is accompanied by any of the other warning signs in this list, is a metabolic red flag. Treat it as one. Warning sign 2. The darkened skin. Look at the back of your neck. Look at your armpits. Look at the skin creases of your groin. and the undersurface of your breasts if you are a woman. Look at your knuckles. In some individuals with significant insulin resistance, particularly but not exclusively in those who are overweight or obese, the chronically elevated insulin levels that characterize compensatory hyperinsulinemia stimulate the proliferation of skin cells and the overproduction of melanin pigment in skin folds and pressure areas, producing a characteristic darkened, velvety, thickened skin discoloration called acanthosis nigricans. This is not a cosmetic issue, it is not a hygiene issue, it is not sun damage. It is the skin's visible response to chronically elevated insulin, one of the most specific and most consistently overlooked cutaneous markers of insulin resistance available to clinical observation. Many individuals with this finding have been told it is a skin condition. Many have been prescribed topical treatments addressing the appearance without any investigation of the metabolic cause. And many have been living with this specific, clinically significant marker of insulin resistance on their skin for years, without ever having a physician connect it to their metabolic risk profile. If you have this finding anywhere on your body, and you have not been specifically evaluated for insulin resistance and prediabetes, that evaluation needs to happen now. Warning sign 3. The wounds that will not heal. A cut on your finger that takes 3 weeks to close. A blister from a shoe that becomes inflamed and lingers for a month. A minor abrasion that develops a stubborn crust and refuses to progress through normal healing stages. In the context of insulin resistance and elevated blood glucose, the normal physiology of wound healing is impaired through multiple simultaneous mechanisms. Hyperglycemia impairs neutrophil function, the first responder immune cells responsible for the initial debridement of wound sites and the prevention of bacterial colonization. It impairs the proliferative activity of fibroblasts, the cells responsible for collagen synthesis and wound closure. It reduces the growth factor signaling required for angiogenesis, the formation of new blood vessels that supply the healing wound with the oxygen and nutrients required for tissue regeneration. And it creates a pro-inflammatory, pro-oxidative wound environment that actively antagonizes the tissue repair process. The result is delayed, incomplete, and infection-prone wound healing that is disproportionate to the severity of the injury, and that represents not merely a practical inconvenience, but a specific and clinically significant indicator of the metabolic and vascular dysfunction underlying insulin resistance. You should not be requiring 3 weeks to heal a minor cut. That is not aging. That is metabolic disease expressing itself at the tissue level. Warning sign 4. The recurring infections. Urinary tract infections occurring 2, 3, or 4 times per year. Yeast infections recurring with a frequency that seems disproportionate. Skin infections developing from minor abrasions or insect bites. Gum disease progressing despite consistent oral hygiene. Fungal infections of the toenails or skin folds, proving resistant to standard treatment. Elevated blood glucose, even at the pre-diabetic threshold, before the formal diagnostic criteria for type 2 diabetes are met, creates a systemic impairment of immune function through several specific mechanisms. Glucose at elevated concentrations directly impairs the chemotaxis, phagocytosis, and intracellular killing capacity of neutrophils, making them less effective at neutralizing bacterial and fungal pathogens. Elevated glucose also provides an abundant substrate for bacterial and fungal growth, literally feeding the pathogens that the immune system is simultaneously less equipped to combat. And the glycosylation of immunoglobulins, the modification of immune proteins by glucose at elevated concentrations, reduces their capacity to bind and neutralize pathogens effectively. The net result is a state of acquired immune dysfunction, not the profound immunosuppression of chemotherapy or HIV, but a meaningful, measurable impairment in infectious disease resistance that manifests clinically as the pattern of recurring infections that many older adults have normalized as simply their personal susceptibility to illness. If you are getting urinary tract infections more than once a year, if yeast infections are recurring with unusual frequency, if your gum disease is progressing despite dentist visits and diligent home care, These are not random bad luck. They are potential metabolic warning signals that deserve metabolic investigation. Warning sign. 5. The vision changes, nobody investigates. Not the sudden blurred vision of the textbook diabetes symptom list, something subtler, more fluctuating, more difficult to characterize. A periodic blurring that comes and goes with no consistent pattern. Difficulty with near vision that seems to vary day to day in a way that cannot be fully explained by your current prescription. A subtle increase in difficulty with contrast or low light vision. The lens of the eye is exquisitely sensitive to changes in blood glucose concentration because the lens relies on simple diffusion rather than active transport for glucose uptake, meaning that lens glucose concentration fluctuates passively with blood glucose levels. When blood glucose rises, glucose enters the lens and is converted to sorbitol through the aldose reductase pathway, an enzyme present in lens cells. Sorbitol accumulates within lens cells because it cannot exit as readily as glucose entered, creating an osmotic gradient that draws water into the lens, altering its refractive properties and producing the fluctuating vision changes characteristic of early glycemic dysregulation. This is why the vision fluctuations of early insulin resistance and prediabetes are specifically variable. Better when blood glucose is lower, worse when blood glucose is elevated, in a pattern that follows the glycemic fluctuations of the day and is often correlated, though rarely consciously so, with large carbohydrate meals. If your vision fluctuates in a pattern that your optometrist cannot fully account for with a stable prescription, and particularly if it seems worse after large meals and better in the morning, this is a potential metabolic warning sign that warrants blood glucose evaluation alongside the standard optometric assessment. Warning sign. 6. The tingling and numbness. Tingling, numbness, a burning discomfort, a sensation of walking on sand or on a surface that is not quite real. Reduced sensitivity in the feet and lower legs that makes walking feel slightly disconnected from the ground. These are the early clinical expressions of peripheral neuropathy, the damage to the small nerve fibers of the peripheral nervous system that is one of the earliest and most specific complications of metabolic dysfunction in the context of elevated blood glucose. The critical clinical point, and the one that is most consistently missed in the standard diabetes narrative, is that peripheral neuropathy in the context of metabolic disease does not begin at the point of formal diabetes diagnosis. It begins during the pre-diabetic transition, when blood glucose levels have been sufficiently elevated for long enough to initiate the specific neurochemical processes that damage small nerve fibers. The mechanisms include the same aldose reductase pathway discussed in the context of lens changes, producing sorbitol accumulation in Schwann cells, the supporting cells of peripheral nerve fibers, disrupting their function and structural integrity. Advanced glycation end products accumulate in the myelin sheaths surrounding peripheral nerves, impairing their conductive properties. And the endoneural microvasculature, the tiny blood vessels supplying peripheral nerve fibers, is damaged by the same endothelial dysfunction and inflammatory processes that affect all small blood vessels in the context of glycemic dysregulation. The result is a length-dependent small fiber neuropathy, beginning in the longest nerve fibers, which supply the most distal parts of the extremities, and progressing centrally over time, which is why the earliest symptoms characteristically appear in the feet and toes, progress to the ankles and lower legs, and only in advanced stages affect the hands and fingers. Any tingling, numbness, burning, or altered sensation in the feet and lower legs, particularly if bilateral and symmetrical, in an adult over 60 who has not been specifically evaluated for metabolic dysfunction, represents a clinical indication for blood glucose evaluation, without exception. Warning. Sign 7. The cognitive fog. Difficulty finding words in conversation. A slowing of mental processing speed that you notice most clearly in complex situations requiring rapid information processing or multi-step problem solving. A subtle but consistent reduction in the sharpness and clarity of thinking that you knew in your 50s. The relationship between insulin resistance and cognitive function is now one of the most extensively researched areas in the intersection of metabolic and neurological medicine. And the evidence documenting this relationship is both robust and genuinely alarming. The brain is one of the most insulin-sensitive organs in the body. Insulin receptors are densely expressed throughout the hippocampus and prefrontal cortex, the brain regions most specifically responsible for memory formation and executive function, respectively. Insulin signaling in these regions plays direct roles in synaptic plasticity, in the regulation of neurotransmitter release, and in the clearance of amyloid beta, the same pathological protein whose accumulation characterizes Alzheimer's disease. When peripheral insulin resistance extends to the brain, producing what researchers have increasingly termed central insulin resistance or type 3 diabetes, these insulin-dependent cognitive functions are progressively impaired. The hippocampus demonstrates measurable volume reduction in individuals with insulin resistance and prediabetes, independent of age. Cognitive performance on tests of episodic memory, processing speed, and executive function is measurably worse in individuals with elevated fasting insulin compared to age-matched individuals with normal insulin sensitivity, even before the formal diagnostic threshold for type 2 diabetes is crossed. The cognitive fog you have been calling aging. The word-finding difficulty you have been attributing to normal senior moments. The processing speed reduction you have been accepting as the inevitable dulling of mental acuity with age. These may not be aging. They may be the earliest cognitive manifestation of the same insulin resistance that is simultaneously damaging your peripheral nerves, your endothelium, and your kidneys. This changes the urgency of the metabolic evaluation significantly. Because addressing insulin resistance is not only a strategy for preventing type 2 diabetes, it is a strategy for protecting the cognitive function you depend on for everything you value about your independent life. Warning sign. 8. The cardiovascular signals. Elevated triglycerides on a routine blood panel, particularly above 150 milligrams per deciliter, and especially if elevated in the context of low HDL cholesterol, below 40 milligrams per deciliter in men or below 50 in women. Elevated blood pressure, particularly systolic hypertension, in the absence of a clear alternative explanation. A resting heart rate that seems persistently elevated above its historical baseline for no identified reason. These cardiovascular biomarkers and physiological changes are not separate from the metabolic dysfunction we have been discussing throughout this section. They are its cardiovascular expression, the measurable manifestation, in the cardiovascular system specifically, of the same insulin resistance and compensatory hyperinsulinemia that are simultaneously producing the skin changes, the neuropathy, the immune dysfunction, and the cognitive fog discussed in the preceding warning signs. The combination of elevated triglycerides, low HDL cholesterol, elevated blood pressure, elevated fasting blood glucose, and abdominal obesity defines the clinical entity of metabolic syndrome, a constellation of findings that represents the cardiovascular and metabolic expression of insulin resistance, and that carries a dramatically elevated risk of both type 2 diabetes and cardiovascular disease compared to any individual component in isolation. If your most recent blood panel showed elevated triglycerides, particularly if this is a change from your historical values, if your HDL has been trending downward, if your blood pressure has required increasing pharmacological management over recent years, these findings, considered in combination rather than in isolation, paint a specific and actionable metabolic picture that deserves a targeted and comprehensive metabolic evaluation. The diagnostic evaluation for insulin resistance, prediabetes, and early type 2 diabetes in an adult over 60 should not be limited to the fasting blood glucose measurement that appears on the standard annual metabolic panel. Fasting blood glucose is a deeply inadequate screening tool for metabolic dysfunction in the older adult population for a specific and important reason. It captures glucose regulation only during the fasting state, the physiological condition that, in many individuals with early insulin resistance, remains relatively well preserved while postprandial glucose regulation, The management of blood glucose following carbohydrate consumption is already significantly impaired. The individual who fasts for 12 hours, presents for a morning blood draw, and receives a fasting glucose of 95 milligrams per deciliter, well within the normal range, may spend the following 8 hours of their post-breakfast, post-lunch, and post-dinner waking life with blood glucose levels that remain significantly elevated for 2, 3, or 4 hours following each meal, producing the same endothelial damage, the same advanced glycation end product accumulation, and the same peripheral nerve fiber toxicity as established diabetes. While their annual metabolic panel continues to show a normal fasting glucose year after year, the diagnostic tools that provide a more complete picture of metabolic function include the following. Hemoglobin A1C, a measurement of the average blood glucose concentration over the preceding 2 to 3 months, reflecting the degree to which glucose has non-enzymatically attached to hemoglobin molecules in circulating red blood cells. An HbA1c below 5.7% is considered normal. Between 5.7 and 6.4% defines prediabetes. 6.5% or above on 2 separate measurements defines type 2 diabetes. This single measurement provides a 2 to 3 month metabolic snapshot that the fasting glucose cannot, and it is available on any standard blood panel at any primary care office. Fasting insulin, a measurement not typically included on standard metabolic panels, but available as an add-on test at most clinical laboratories, allows the calculation of HOMA-IR, the homeostatic model assessment of insulin resistance, which directly quantifies the degree of peripheral insulin resistance present, independent of whether fasting glucose or HbA1c have yet crossed the diagnostic thresholds for prediabetes or diabetes. Elevated fasting insulin with normal fasting glucose, the most common early pattern of insulin resistance, is entirely invisible to the standard annual blood panel unless fasting insulin is specifically requested. A 2-hour postprandial glucose measurement, either through a formal 2-hour oral glucose tolerance test or through practical self-monitoring of blood glucose, 2 hours following a standard meal using a home glucose meter, directly assesses postprandial glucose regulation and identifies the impaired glucose tolerance that represents the earliest functionally significant form of metabolic dysfunction in many older adults. A complete lipid panel, with specific attention to fasting triglycerides and HDL cholesterol levels, provides the cardiovascular metabolic biomarkers discussed in the previous section, whose pattern is diagnostically informative about underlying insulin resistance even before formal glucose dysregulation criteria are met. Bring this list to your next physician appointment. Request each of these measurements by name. If your physician is resistant to ordering fasting insulin or a 2-hour postprandial glucose, both of which are legitimate, guideline-supported clinical investigations for an adult over 60 with any of the warning signs discussed in the previous section, ask for a referral to an endocrinologist. Your metabolic evaluation should be as comprehensive as the metabolic risk it is designed to assess. Now we arrive at the part of this conversation that makes people uncomfortable, because the biological mechanisms of insulin resistance and prediabetes are not purely the result of genetic bad luck or the unavoidable consequences of aging. They are substantially, not entirely, but substantially, the consequence of daily behavioral choices. And those choices are yours to make differently starting today. Stop eating carbohydrates like you are 35. This is not a diet recommendation. It is a metabolic reality. The pancreatic beta cell capacity to produce compensatory insulin in response to carbohydrate-driven glucose declines with age. The peripheral insulin sensitivity of muscle and adipose tissue declines with age. The postprandial glucose clearance capacity of the aging metabolic system is meaningfully less efficient than it was 2 decades ago. Stop sitting for 6 to 8 hours a day and calling yourself physically active because you exercise for 30 minutes in the morning. As established in our very first video on this channel, the metabolic consequences of prolonged, uninterrupted sitting, the suppression of lipoprotein lipase activity, the impairment of postprandial glucose clearance, the accumulation of circulating triglycerides, occur in real time during each uninterrupted sitting episode, independently of what exercise was performed earlier in the day. For individuals with insulin resistance or prediabetes specifically, the postprandial period, the 2 to 3 hours following each meal during which blood glucose is rising, represents the highest risk window for hyperglycemic exposure and its associated endothelial and nerve fiber damage. And prolonged sitting during this postprandial window dramatically impairs the muscle's capacity to participate in the insulin-independent glucose disposal that would otherwise attenuate the glucose rise. A 10-minute walk after each meal, standing and moving for 2 to 3 minutes every 30 to 45 minutes of sitting. These are not minor lifestyle tweaks. They are direct, mechanistically grounded metabolic interventions that produce measurable reductions in postprandial glucose elevation. In some studies, reductions comparable to those achieved by metformin, the most commonly prescribed first-line pharmacological agent for type 2 diabetes prevention. Stop treating your sleep as a lifestyle variable that you adjust according to the competing demands of your schedule. As established in the previous video, sleep deprivation produces insulin resistance. Not eventually, not theoretically, but within days of sustained inadequate sleep, through direct impairment of the insulin signaling pathways in peripheral tissues. Every night of inadequate slow-wave sleep is a night during which the growth hormone that would otherwise promote insulin sensitivity is not being adequately secreted. Every night of obstructive sleep apnea is a night producing repeated cortisol pulses that directly impair peripheral glucose uptake. If you are managing your blood glucose through dietary and exercise interventions during your waking hours and ignoring the metabolic consequences of your sleep quality, you are addressing 2/3 of the picture and leaving 1/3, the nocturnal metabolic environment, completely unmanaged. Your sleep is not separate from your metabolic health. It is metabolic health. Address it accordingly. If the diagnostic evaluation confirms prediabetes or early type 2 diabetes, or if the warning signs discussed throughout this video are present in your clinical picture, the interventions that the evidence most strongly supports are specific, hierarchically organized, and substantially more effective than the generic lifestyle advice that most individuals receive in a 12-minute clinical encounter. The Diabetes Prevention Program, the landmark randomized controlled trial that established the evidence base for structured lifestyle intervention in prediabetes, demonstrated that an intensive lifestyle intervention focused on weight loss through dietary modification and increased physical activity reduced progression from prediabetes to type 2 diabetes by 58% over a 3-year follow-up period, more effectively than metformin, which reduced progression by 31% in the same trial. But the lifestyle intervention in this trial was not a generic recommendation to eat better and exercise more. It was a structured program with specific targets, a 7% reduction in body weight, achieved and maintained through a combination of caloric reduction, dietary composition changes, and a minimum of 150 minutes of moderate intensity physical activity per week. The specific dietary changes most strongly supported by the evidence for improving insulin sensitivity and reducing progression from prediabetes to type 2 diabetes include a meaningful reduction in refined carbohydrate and added sugar intake, with substitution of higher fiber, lower glycemic carbohydrate sources, vegetables, legumes, intact whole grains, and most whole fruits. Combined with adequate dietary protein as established in our previous video, and the adoption of a Mediterranean-style overall dietary pattern, which has demonstrated independent benefit for insulin sensitivity and metabolic outcomes in multiple large randomized controlled trials. Resistance training, as established in our video on visceral fat, directly improves insulin sensitivity through its effects on muscle glucose transporter expression and activity, and is specifically recommended in combination with aerobic exercise for metabolic risk management in the current American Diabetes Association clinical practice guidelines. The timing of carbohydrate consumption relative to physical activity and across the day consuming the majority of carbohydrate intake in the earlier parts of the day when insulin sensitivity is highest, and distributing protein intake across meals to maximize muscle protein synthesis and satiety, represents a dietary architecture that optimizes postprandial glucose management beyond what any single food choice change can achieve in isolation. Metformin, the most extensively studied pharmacological agent for diabetes prevention and management, is appropriate for discussion with your physician if lifestyle modification alone is insufficient to achieve target metabolic outcomes. If HbA1c progression is occurring despite lifestyle intervention, or if specific clinical circumstances, including age over 60 with multiple cardiovascular risk factors, make pharmacological augmentation of lifestyle intervention clinically prudent. The critical principle underlying all of these interventions is that the metabolic dysfunction we have been discussing throughout this video is not a binary state, present or absent, diabetic or non-diabetic, but a continuous spectrum. And every point along that spectrum, from early insulin resistance through prediabetes to established type 2 diabetes, represents a metabolic environment that is responsive to targeted intervention, not equally responsive at every stage, and not equally reversible at every stage, but responsive nonetheless. The individual who identifies and addresses insulin resistance at the stage of early warning signs is working with a profoundly more malleable biological system than the individual who waits for the formal diabetes diagnosis and the established end organ damage that may accompany it. The window is open. The question is whether you will step through it. One of the most empowering shifts available to any adult over 60 who is managing or seeking to prevent metabolic disease is the shift from passive, once-yearly measurement of metabolic markers in a clinical setting to active, ongoing self-monitoring of metabolic function in daily life. The most accessible and most immediately informative tool for this purpose is the home blood glucose monitor, a device that measures capillary blood glucose from a small fingertip lancet sample in approximately 5 seconds, available at any pharmacy without a prescription for approximately $15 to $20, with ongoing test strip costs of approximately 30 to 50 cents per test. Used strategically, rather than simply as a tool for monitoring established diabetes, the home blood glucose monitor provides real-time, actionable feedback on the metabolic consequences of specific dietary choices, meal compositions, activity patterns, and sleep quality that no amount of dietary journaling or general health advice can replicate. Testing blood glucose 2 hours after a specific meal, noting whether the 2-hour value has returned to within 40 milligrams per deciliter of the pre-meal fasting value, the target that current clinical guidelines suggest for postprandial glucose management, provides immediate objective feedback on that specific meal's glycemic impact on your individual metabolic system. This feedback is more personalized, more immediately actionable, and more metabolically informative than any generic glycemic index table or dietary guideline, because glycemic responses to specific foods vary substantially between individuals based on their specific gut microbiome composition, their degree of insulin resistance, their current level of physical fitness, and their meal history across the preceding hours. The 2-hour post-meal glucose target for adults with prediabetes or early diabetes is less than 140 milligrams per deciliter, and consistently achieving this target across all meals has been shown to substantially reduce the postprandial glucose exposure responsible for much of the endothelial, neural, and renal damage of metabolic disease. Continuous glucose monitoring, wearable biosensor devices that measure interstitial glucose continuously throughout the day and night, providing a complete picture of 24-hour glucose dynamics, including nocturnal patterns, meal response curves, and the impact of exercise and sleep on glucose regulation, has become increasingly accessible and affordable, and represents the most comprehensive available tool for metabolic self-awareness in the management and prevention of type 2 diabetes. Several continuous glucose monitoring devices are now available without a prescription for short-term use, and provide a level of metabolic self-knowledge that fundamentally transforms the ability to make informed, effective dietary and lifestyle choices. The regular measurement and tracking of waist circumference at the level of the navel, at the same time each week under consistent conditions, provides a simple, free, and surprisingly informative proxy for visceral fat accumulation and the insulin resistance that accompanies it, complementing the laboratory and glucose monitoring data with an easily trackable anthropometric marker of metabolic risk. This section is not comfortable, it is necessary. There are consequences of prolonged, unaddressed metabolic dysfunction, of years of prediabetes progressing undetected, of years of postprandial hyperglycemia occurring beneath the threshold of fasting glucose diagnosis, of years of the warning signs discussed in this video being dismissed or normalized that are not reversible. The peripheral neuropathy that develops over years of metabolic nerve fiber damage does not fully resolve with metabolic normalization. The nerve fibers that have degenerated do not regenerate with the same speed or completeness with which the metabolic dysfunction that caused their degeneration can be addressed. Early neuropathy can stabilize and partially improve with aggressive metabolic management. Advanced neuropathy cannot be meaningfully reversed. The diabetic retinopathy that develops from years of microvascular damage to the blood vessels of the retina, the light-sensitive tissue at the back of the eye that converts visual information into neural signals, produces progressive visual loss that, at its advanced stages, represents one of the leading causes of new-onset blindness in American adults. Early diabetic retinopathy identified and managed before the development of clinically significant macular edema or proliferative disease is highly responsive to intervention. Established proliferative retinopathy with tractional retinal changes represents damage that treatment can slow but not reverse. The chronic kidney disease that results from diabetic nephropathy, the progressive glomerular and tubulo-interstitial damage driven by years of glycemic and hemodynamic stress on the renal microvasculature, reduces kidney filtration capacity in a pattern that, beyond a certain threshold of nephron loss, progresses independently of subsequent glycemic control. Early diabetic nephropathy identified and managed aggressively can be substantially slowed. Established stage 3 to 4 chronic kidney disease represents a trajectory toward dialysis dependence that metabolic intervention can slow but cannot fully reverse. The cardiovascular disease that results from years of endothelial dysfunction, accelerated atherosclerosis, and the direct cardiotoxic effects of advanced glycation end products on the myocardium, resulting in the 2 to 4 times higher cardiovascular mortality risk that characterizes established type 2 diabetes. Represents atherosclerotic burden that, once accumulated in the coronary and peripheral arterial walls, cannot be meaningfully removed through metabolic normalization alone. These are not meant as counsel of despair. They are the honest statement of why the window of early intervention, the window that the warning signs discussed in this video provide access to, is so clinically precious and so consequentially narrow. Every year of prediabetes that passes unaddressed is a year of irreversible damage accumulation. The damage that has already occurred cannot be undone. The damage that has not yet occurred can still be prevented. Which side of that statement you are on right now is something you need to find out. Through evaluation, through investigation, through the diagnostic workup discussed in this video. And the time to find out is not at your next annual physical if that is 6 months away. It is now. You have just spent the last 50 minutes receiving information that tens of millions of Americans over 60 have never been given with this degree of clarity and specificity. The warning signs that appear years before the textbook diabetes diagnosis. The diagnostic tools that detect metabolic dysfunction that the standard annual blood panel misses. The behavioral choices that are either accelerating or decelerating the metabolic dysfunction that may already be underway in your body. The window of intervention that is open right now and that will not remain equally open indefinitely. The only question remaining is what you are going to do with this information. Because information without action is not health education. It is an elaborate way of feeling informed while changing nothing. Here is what action looks like. Today, Not this week. Not at your next checkup. Today. You look at the 8 warning signs covered in this video, and you honestly assess how many of them apply to you. Not the ones that are easy to dismiss. All of them. The fatigue that does not resolve with rest. The skin changes in your body folds. The wounds that heal more slowly than they used to. The recurring infections. The fluctuating vision. The tingling in your feet. The cognitive fog. The elevated triglycerides on your last blood panel. If 3 or more of these apply to you, and for a significant proportion of adults over 60, they will, you call your physician's office today and you schedule an appointment specifically for metabolic evaluation, not your next annual physical. A specific appointment for this specific purpose, as soon as your physician's schedule allows. At that appointment, you request, by name, an HbA1c, a fasting insulin, a fasting lipid panel with specific attention to triglycerides and HDL, and a discussion of whether a 2-hour oral glucose tolerance test is clinically indicated given your symptom profile and risk factors. You do not leave that appointment with a fasting glucose result and a recommendation to watch your diet. You leave with a complete metabolic picture, or you return until you have one. You look at your daily carbohydrate intake with honest eyes, not dietary perfectionism. Honest assessment. Are you consuming refined carbohydrates, white bread, white rice, pasta, processed cereals, sweetened beverages, pastries, as a regular and substantial component of your daily diet? If yes, that changes today. Not perfectly, not completely, but meaningfully and immediately. You buy a home blood glucose monitor, $15 to $20 at any pharmacy. You use it to measure your blood glucose 2 hours after your typical dinner, the meal that is most likely to produce your highest postprandial glucose response, for the next 7 days. You record the results. You bring them to your next physician appointment. What you learn in those 7 days about your personal metabolic response to your actual diet will be more clinically informative than any amount of generic dietary advice. And you treat your sleep, tonight and every night, with the metabolic urgency it deserves. Because the nocturnal metabolic environment is not a peripheral lifestyle variable. It is a direct determinant of your insulin sensitivity, your cortisol regulation, and your cardiovascular risk, operating every night, regardless of what you do during your waking hours. The metabolic dysfunction that is silently progressing in the bodies of millions of Americans over 60 right now is not unstoppable. It is not inevitable. And it is not beyond the reach of specific, targeted, evidence-based intervention. But intervention requires recognition, and recognition requires exactly the knowledge you now possess. You know what the warning signs look like. You know what the evaluation requires. You know what the interventions are. You know what is at stake if you wait and what becomes possible if you act. The only remaining question is one only you can answer. What are you going to do with what you now know?